Hello, I am Dr. Arinze Aikemi. I'm a hospitalist, internist. I'm also a nephrologist, and I am one of the associate professors of Campbell University in North Carolina. I do teach medical students. Today I want to go through acute respiratory failure support options. And this is mostly for medical students and also for new physicians who are recently going into the inpatient settings to take care of patients hospitalized. And I'm hoping that this is a short presentation just to give you some idea on what your support options are. Acute respiratory failure is a secondary diagnosis. There is usually a primary process like pneumonia, heart failure, or pulmonary edema, and they go into respiratory failure. So as you manage the primary process, you want to know what your support options are in these cases of acute respiratory failure. The scope of my discussion, I'm going to be talking about the respiratory system, just a little bit on the physiology, the definition of acute respiratory failure, types of acute respiratory failure, primary causes, like I mentioned, of acute respiratory failure. And the major part of the discussion is going to be your support options. While you're treating the primary process, you want to know what your support options are for the acute respiratory failure. So in most treatments in the hospital, you're going to have the primary treatment and then the supportive management. So this again is the supportive management for acute respiratory failure. So a little bit on physiology of the respiratory system. This diagram is just to mention that the control of your respiratory system starts from the brain stem to be precise, which is the medulla mainly, a little bit from the pons, and then it affects the breathing. And of course, at the cellular microscopic level in the lungs, there is exchange of gas in the alveoli, between the blood in the capillaries and, and the lungs, the alveoli. So that's what this diagram tries to show. So the respiratory center, as I mentioned, it's located in the medulla, the part of the midbrain. It gets its signals from chemoreceptors. There are central chemoreceptors, which are more in the brain. There are peripheral ones, which are more in the peripheral circulation. They detect the blood carbon dioxide and pH levels, especially the central chemoreceptors. The peripheral ones tend to notice the oxygen levels, and there are also long stretch receptors located in the lungs that send signals that tell the brain when the lungs are fully inflated to initiate expiration. So it controls the breathing by sending signals to the respiratory muscles, and it contains a group of neurons that work together in the brainstem to regulate the breathing. There is the dorsal respiratory group we call the DRG that initiates the inspiration. There's the ventral respiratory group that controls expiration and also fine-tunes the breathing rhythm. And of course, the pontine respiratory group, the PRG, modulates the DRG and the VRG, influencing the duration and the depth of breath. So, of course, while the cerebrum, there is a voluntary aspect of breathing where you can decide to take deep breaths or breathe out or hold your breath. There is more specialized reflexes in the brainstem that control breathing. So even when you're sleeping or when people are unconscious, they still breathe. So again, this is just a diagram showing the brain, again, the brainstem, the medulla, with the different centers, the respiratory group centers we talked about, the lungs, the respiratory muscles, and how signals go up and down. It's sort of a communication between the brain and the lungs. So let's talk about definition, the types of acute respiratory failure. Acute respiratory failure occurs when the respiratory system that we just talked about is unable to maintain normal levels of oxygen and carbon dioxide in the body. We already know you breathe in oxygen and then you breathe out carbon dioxide. So when there is a failure in this system, then you have an acute respiratory failure. So you do have the acute hypoxic respiratory failure, where oxygen is the major problem. The ABG's oxygen pressure is less than 60 millimeters mercury, or the oxygen saturation, which you can measure, with a pulse ox, is less than 90%. And possible causes include lung conditions like pneumonia, pulmonary edema in heart failure, pulmonary embolism, aspiration, pulmonary contusions in trauma cases. And you also have the acute hypercapnic respiratory failure, where the carbon dioxide pressure is higher than normal, which is 45 millimeters mercury. And some of the possible causes can come from the lungs, like COPD exacerbation, pulmonary edema, can come from musculoskeletal disorders affecting your breathing, like muscular dystrophies, obesity, hypoventilation syndrome, deformities in the chest like kyphoscoliosis, myopathies, etc. Of course, brainstem disorders, like we mentioned, the brainstem does get involved in respiratory drive. And so when there is, brainstem strokes, ALS, especially in advanced cases, or drug overdose cases where the benzodiazepines or the opioids suppress the breathing center, the respiratory center, that can also lead to acute hypercapnic respiratory failure. So again, management of acute respiratory failure involves treating the primary underlying cause, the pneumonias, the heart failure or pulmonary edema. But then the supportive management is also part of your management, where you need oxygen delivery systems or some form of ventilation when there is a ventilation failure in the patient. So what are some of those supportive management options? So let's start with the acute hypoxic respiratory failure, where the oxygen level is low. You have the non-invasive support systems and, of course, the invasive one, which is the vent. So first of all, when the oxygen is low, we usually start with nasal cannula oxygen that can provide 2 to 6 liters per minute of oxygen and oxygen fraction up to 24-40%. And then if that doesn't work and oxygen is still low, you can go to the high flow nasal cannula, which can go as high as 15 liters per minute. Then the veni mask. The veni mask can still go up to 15 liters, but the advantage is, sometimes you can get oxygen saturation fraction up to 50%. And especially for mouth breathers, or people who are tachypnic, the veni mask can definitely help, because you can deliver oxygen both through the nose and through the mouth. Now, the non-rebreather oxygen is a famous one that, the EMS team will use very commonly, and it can go up to 15 liters also, but the oxygen fraction can actually go as high as 80%. And what's important that makes it different from the veni mask is the respiratory rates can actually be an advantage. So while the patient is tachypnic, breathing real fast, that can actually increase the oxygen delivery up to 80% oxygen fraction, despite the flow rate still being at 15 liters. And of course, there is a system that, the next system, a lot of providers don't even know about this, but we do have the heated high flow system. You would hear words like Evo, Optiflow, Vapotherm, and can go up to 60 liters per minute, and oxygen fraction can be as high as 100%. And this is because there is a small PEEP, what we call a peak end expiratory pressure, where the lungs never fully collapse and stay open. And so that helps with better oxygen delivery than some of these other systems that we've talked about. And of course, if all these fails, then we intubate the patient and become invasive with the ventilator. And that the diagram there, it just shows the diagrams of what we just discussed. So what about acute hypercapnic respiratory failure? Again, the non-invasive ones, they are what we call non-invasive positive pressure ventilation. Again, this is a ventilation failure where oxygenation might not be a problem, but they can blow out their carbon dioxide. And, the BiPAP, which is the bi-level positive airway pressure, is a major one that we use in the hospitals. There are usually 2 pressure settings, one for inspiration, which is higher, and then when you expire, or when you breathe out, when you exhale, the pressure is much lower. And so the respiratory therapy is kind of juggles between going up on the inspiratory pressure and the expiratory pressure to get to a volume that, they feel can actually ventilate the patient. Then, of course, you have options like continuous positive airway pressure, usually mostly for CPAP, mostly for obstructive sleep apnea patients, because it's only one pressure setting and it can be uncomfortable because it's a continuous pressure. We have the AutoPAP, the APAP, where the pressure varies and it's automated based on needs. And we have the Trilogy machine, It's an expensive machine, but it tries to target a volume for each breath, and so the pressure supports varies with a target volume so that the patient gets a particular volume with every breath, and it's a pretty good one, better tolerated, and it also adjusts for upper airway pressures in those with large necks or any kind of obstruction. And of course, if this doesn't work, you repeat your ABG, your arterial blood gas, and the PCO2 is getting worse or not improving even at high pressures, then of course you have to intubate the patient and put them on the ventilator, which is more invasive. So again, this is a short lecture, that's pretty much it. But again, just to, emphasize that, management of acute respiratory failure involves treating the underlying cause. You treat the pneumonia, you diurese the patient if it's pulmonary edema, but then you do have these supportive management options to deliver more oxygen or to ventilate the patients when they go into respiratory failure. Thank you.